Hello and welcome to this week's Key Opinion Leader webinar. Today I'd like to welcome Mr. Adil Ajuied. If you can say hello. There we go. So he's muted at the moment. We'll unmute him in a second. Before we start this week's session, I'd just like to do a few housekeeping rules as we always do. So just gonna pop through those. So we have a Q&A function, which please can you put all the questions through the Q&A function? There we go. You're back in, Adil. And then if any questions don't get answered straight away, we will come back to them at the end. You can also use the chat function, but please, any questions just go through the Q&A. It will be recorded, and this will be put on the Össur Academy YouTube channel, so you can search there for any of the previous sessions. We also will be sending out e-certificates. Now, I've had a few people just phoning in to check whether they've received them, and sometimes they will go into the junk email file. So do check that just to make sure that they're in there. There's also a follow-up questionnaire in there as well. So I'm going to start by telling you a little bit about Mr. Ajuied, but a bit more sort of recent information. He was recently redeployed to the NHS Nightingale Hospital in London. So I'm sure you got a few questions to ask him about that as well. So just going to go through a little bit of information about Mr. Ajuied. So he's worked as a consultant at Guy's and St Thomas since February 2009, having qualified as a doctor at the medical school there, and he's trained at a number of level 1 trauma centres and has worked throughout London and the southeast. He's been appointed as senior honorary clinical lecturer in trauma and orthopaedics, as well as director of education for South London Orthopaedics in recognition of his contributions to higher surgical training. He's travelled and worked in many countries, from Belgium to South Africa, and in 2008 he worked in Johannesburg, where he held an appointment as an honorary consultant, and while in South Africa he established a dedicated knee injury service which continues to serve the local community to this day. Just really remains for me to pass over to Adil, and then he can start his presentation. The process of sharing screen is a bit of a technical thing, so bear with us. Perfect. Over to you, Mr. Ajuied.
No problem. Thank you very much, Giles, for your very kind introduction. And it's a great pleasure to be with you today, guys, and having the opportunity to talk to you a little bit about some regular clinical medicine and clinical orthopedics in these very unusual and unprecedented times. I hope that you and your families are all keeping well and keeping safe, and I really look forward to this coming session. So I'm going to be talking about multi-ligament knee injuries and contemporary treatment strategies, including ligament downgrading and optimized non-operative treatment. As Giles mentioned, I work at Guy's and St Thomas's, and I'd also like to just mention, in the interest of openness and transparency, that I have no financial conflict of interest in relation to this talk or in relation to any of the products or services mentioned. So I work at Guy's and St Thomas's in the NHS, and independently I work at the Fortune Clinic. Here you see the amazing, stunning architectural marvel that is Guy's Hospital, which is the tallest hospital in the Northern Hemisphere, and used to give you beautiful views of northeast London until someone built this right beside us. You're always more than welcome to come and visit anytime, and please feel free to reach out at any point after lockdown. So I'm just going to hand over to Giles for some poll questions.
Okay, so we have a few polls initially. We'd like to have this one in because it gives the speaker a good idea of what his audience is. So what is your role? Are you a surgeon? Are you a non-operative surgeon or sports physician, physio, orthotist, podiatrist, OT, or other? So we just click on that and then click submit. And we have, already 80% already answered. So I'm going to end polling there and share those results. So you can see we have 4% surgeons. We have one person who's a non-elective surgeon or sports physician, 73% physios, 14% orthotists, and 9% other. Okay. So we've got 3 polls in the initial section. So we're going to go on to that one, and then following by one more, and that's how many multi-ligament knee injuries have you seen in the last year? 0 to 5, 5 to 10, or more than 10? Okay, so we have 70% people have voted. We'll just leave it until it gets just beyond 80. Perfect. Okay, and it's a pretty even split between all 3. So 43% said they've seen 0 to 5, 32% been 5 to 10, and then 25% have said more than 10. So that's interesting. And then I will just go to the final poll of this initial section, and it's would you consider using knee bracing in a patient with an acute multi-ligament knee injury? Okay. So we are up to 80%, and this is fairly conclusive. We have 96% saying yes, they would, and 4% saying no.
Excellent. Thank you very much, Giles. It very much looks like I'm going to be preaching to the converted, which is awesome. So, during this talk, I'd like to talk a little bit about some of the definitions around knee dislocation and multi-ligament knee injuries. We're going to talk about the patient types and the personality of patients who suffer these injuries. We're going to talk quite a bit about the assessment of these patients, especially in the acute setting. And then I'd like to share my journey with regards to ligament downgrading and bracing, which initially started within my PCL practice and is now certainly extended to my multi-ligament practice. We're going to talk a little bit about conventional treatment strategies with multiple injuries and talk about some new concepts and a new pathway in the management of these patients. So, in terms of definition, what is a multi-ligament knee injury? Well, a multi-ligament knee injury is any knee in which there has been injury to 2 or more of the cardinal stabilizing ligamental structures with secondary instability. So the reason instability is important is, for example, we very often say grade 1 MCL, which is structurally stable, sore in the presence of an acute ACL tear. So that wouldn't be a multi-ligament knee injury because only one of those ligaments is unstable. However, if you have a 3 MCL and an ACL tear, that would certainly qualify as being a multi-ligament knee injury. The other reason we like to use the phrase multi-ligament knee injury is that traditionally we used to call these knee dislocations, but that was very often confused with patellar dislocation among our patients and the lay population. So we like to refer to these patients now as multi-ligament knee injuries. So what is the scope of injury that these patients suffer in respect to their knee in particular? Well, obviously, they suffer an injury to multiple ligaments within their knee. However, they also very often will suffer with a concomitant articular injury, which may either be a pure chondral injury or an osteochondral injury. There has been recognized a significant incidence of meniscal injury with up to 20% of these patients suffering with meniscal root tears. There is a significant preponderance of neurological injury, in particular to the peroneal nerve, as it crosses the joint line and makes its way laterally around the neck of the fibula. These neurological injuries may either be in continuity with good potential for healing and recovery, or they may be associated with discontinuity, often requiring peripheral nerve surgery grafting and reconstruction. We then come to vascular injury. So this is a very core topic within multi-ligament knee injuries, as it has the potential to be limb-threatening. Broadly speaking, vascular injuries may either be complete at the point of presentation, in which case they are relatively straightforward to diagnose, or they may be incomplete with damage to the lining of the arterial vessel, referred to as an intimal tear. And in these instances, patients can have runoff and can have blood flow. However, they can form thrombus, clot, and occlude when no one's looking. And it's very, very important to be very mindful of the potential of occult vascular injury in this patient group, as it is really quite prevalent, of the order of about 15 to 20% of these patients. In some instances, there can be periarticular fracture associated with multi-ligament knee injury, and there can be significant injury and disruption to the surrounding skin and soft tissues, which must be taken into account. In terms of classification, I'd just like to mention briefly that there is a classification system, and this is the Schenck Classification. It is used for data collection, data archiving, and for audit and research purposes, although it doesn't really have very much of a clinical application, as we more commonly describe the injury pattern when managing these patients in the clinical setting, or for the purposes of handover, management planning, and MDT. So there are primarily two patient groups that suffer with multi-ligament knee injuries. There are the high energy injuries, which are generally experienced by young, active patients, predominantly male patients. And this can be suffered in the context of contact pivoting sports, or potentially in the context of a road traffic accident. There is one sport which I'd like to mention in particular, which combines both sport and road traffic accidents, and that's motocross. And within motocross, we see a really high incidence of multi-ligament knee injury, among many other injuries, so much so that many professional motocross riders wear knee braces prophylactically, and this forms part of their protective equipment when riding. So I think it's something to bear in mind. Second category and second group of patients are the low energy patients. And these patients tend to have a raised BMI. There's a higher preponderance of females as compared to males. And these patients often have a hyperlax profile. The really marked aspect of their presentation is that these patients suffer catastrophic knee injury in the presence of very innocuous, benign mechanisms of injury. Lifting over carpet, slipping on a CD, and just falling from a standing height. And for this reason, these injuries can often be missed in the acute setting and often can be undertreated or dismissed as either patella dislocations or quote-unquote knee sprains. These patients also have the potential for really very poor outcomes and are very challenging group to manage and treat. So the topic of multi-ligament knee injury is one that is very difficult to research and study. And there is a relative paucity of literature in this area, in particular in relation to outcomes. And the reason for this is that injury patterns tend to be very heterogeneous, depending upon which ligaments are injured, whether or not there's an articular injury, and whether or not there's a significant meniscal injury. The patients themselves are very heterogeneous as to their aspirations, their level of sporting engagement, and whether or not they have other concomitant systemic injuries. So there's clear evidence that these patients often suffer long-term impaired quality of life related to injuries other than their knee that they may well sustain simultaneously. The injury is also relatively rare, resulting in very small sample sizes and almost precluding any form of randomization. And these are the reasons that studying these patient groups tends to be very difficult, and there is certainly no level 1 evidence in relation to multi-ligament knee injuries. In terms of assessing these patients when they present, we assess these patients in accordance with ATLS principles, both simultaneously assessing them and resuscitating them. In respect of limb assessment, we take a detailed history of these patients, and these patients often can give a very clear and distinct history as to their mechanism of injury. There are often witnesses who've observed the injury and often will relay that to the paramedics. And often there can be a history of on-scene reduction of a dislocation as an air splint is being applied to the limb and with Entonox on the field, etc. In this day and age, everyone is a walking cameraman, and very often these patients can present with film footage of their injury, which can be helpful in initial assessment. So in terms of examination, we want to examine these patients' vascular supply and blood supply. And for this, we assess their pulses, their capillary refill, and their ankle brachial index. It's important to note that capillary refill can be a little bit deceptive in these patients, and it's very important not to mistake venous stasis for good capillary refill. We assess these patients neurologically, both in terms of motor and sensory function, and we then assess their soft tissues and the quality of their soft tissue envelope. Their ligamental stability is almost the last thing that we assess, and because the factor that's going to be most correlate with poor outcome and limb threat is their vascular stability. So in terms of vascular assessments, I'd like to just mention some interesting key points. So the British Orthopaedic Association has published guidance in relation to management of arterial injuries associated with dislocations, and they make some interesting observations, which include the fact that the clinical signs of vascular injury can be difficult to identify in the acute setting, that absent pulses must always be taken very seriously, and that the pink pulseless limb must be assumed to have a vascular injury until proven otherwise. And the reason for this is that the limb may still appear to be perfused with a reasonable capillary refill due to the presence of collateral blood supply or a partial occlusion due to intimal injury. So vascular injury really is quite important. I'd like to mention a paper from the Kester Journal. This was a paper from the end of last year from an American group who published an epidemiological study looking at the pan-US trauma database for multi-ligament knee trauma. And they managed to capture almost 6,500 cases of knee dislocation across the entire US over 4 years. And of these patients, approximately 30% underwent investigation for vascular injury, and half of these were shown to have proven vascular injury, of which 11% went on to have vascular intervention. So vascular injury does happen, and we must be very, very vigilant to look for it and suspect it. So on inspection, these knees can appear deformed at presentation, but often the joints have been reduced, but you rapidly develop significant bruising and occasionally some skin dimpling and puckering due to the soft tissues being captured and potentially buttonholing. So in terms of investigations, there are a number of modalities that are open to us. Plain radiographs are extremely valuable and critical, especially in an acute setting. MRI is also invaluable for definitive assessment of ligamental injury and confirming whether there's incontinuity or not for assessing the menisci. And we also use CT and CT angiography. In respect of plain radiographs, they can be used to diagnose the dislocation. Now, it's often said within orthopedics that the x-rays that you're seeing here are x-rays that you should never see, because this joint should have been diagnosed as dislocated clinically and should have been reduced before the x-ray. That is somewhat unfair, especially in patients of a large body habitus where it can be extremely difficult to diagnose a dislocation. So for that reason, I think that a radiograph is a radiograph performed demonstrating a dislocated knee is not a complete sin, and sometimes can be helpful in helping guide and plan your strategy for joint reduction. A plain radiograph can also demonstrate a degree of subluxation, as well as abnormal joint gapping or joint space opening, suggestive of underlying joint laxity, as well as fracture. In terms of MRI is extremely valuable, as I've mentioned, in assessing ligament continuity and stability, assessing the menisci and the meniscal roots, and excluding any potential chondral or osteochondral injury or occult fracture. Here we see a CT angiogram with the red arrow demonstrating a clear occlusion and a block to run off through the distal vascular tree. Here we see, again, a CT angiogram which has been taken rendered, and you can see no distal runoff with a complete occlusion. And lastly, a further CT angiogram, and here you can see that there is some runoff, but there is some dampening effect and partial occlusion indicative of an interval injury. And this is the lesion that if you do not image, you may well miss clinically. So many of us, myself included, will insist upon routine vascular imaging for all of these patients, irrespective of their clinical findings, to be confident that they have no vascular injury.
Mr. Ajuied, Catherine Francis has said, okay, you're using different imaging modalities, but would you go through which pulses you would assess in your...
So clinically, we routinely would assess for the dorsalis pedis and posterior tibial pulses. So dorsalis pedis is located proximally in the first web space, and posterior tibial posterior to the medial malleolus. And these should be palpable. If not palpable, one can assess for them using a Doppler probe, which is often available in A&E resus, or can be borrowed from the vascular ward. But if you can't feel a pulse, then you can't feel a pulse, which is to say that a Doppler probe gives you reassurance that there is some blood flow, but you would expect to be able to palpate a pulse. So if the pulse is only detectable with a Doppler, then that is likely to indicate some diminution of pulsatility, diminution of blood supply. So I would still advocate screening with appropriate vascular imaging. Is that good, John?
That's perfect, thank you.
Excellent. So within the context of the multi-ligament knee, there are a few questions that we need to ask ourselves. These questions go through my mind every single time I see these patients, whether I'm called down to A&E resus to see them, or whether they are presenting to my clinic having had a knee injury over the weekend. I'm presenting to my Monday morning clinic as an urgent patient. These questions run through my mind every single time. So my first question is this knee dislocated? So is there deformity? Is there a possibility that this patient's body habitus is masking the fact that they have dislocated their knee? Is the knee out of joint? My second question is, has this knee been dislocated before I've arrived to see it? So has it reduced from the sporting field? Was it reduced by somebody else? Is there a vascular injury? And is that an active injury, which is to say there is significant diminution of blood supply as I'm looking at the patient? Or is there an occult injury that's going to block off later on when no one's looking at the patient? Has there been a nerve?
So I think we've lost sound from Mr. Ajuied, so we'll give him a moment or so to see if that comes back. Let me just check. Right. So we appear to have lost Mr. Ajuied briefly. So what I'm going to do is I'm going to quickly bring up the poll that basically was about the slide that he's on at the moment. And then hopefully in that time, he'll come back. So I'm just going to launch the polling for that one and just discuss those. So what Mr. Adil was saying is, which of these clinical questions is hardest to answer? So is it dislocated? Has it been dislocated? Is there an active vascular injury? Is there an occult vascular injury? Is there a nervous injury? Is there a fracture? Or is there a soft tissue injury? So Mr. Adil has just popped back now. So we're just in the middle of the poll from the slide that you were doing there, Mr. Ajuied.
Awesome. Thank you.
So we have 60% of people have answered. So we'll keep going until we get to roughly 80. Brilliant. Okay, so I'll stop that there and then share those results. So which of these clinical questions is hardest to answer? Is it dislocated? There's only one person went for that. Has it been dislocated? 20% have gone for that. Is there an active vascular injury? 88%, sorry, have gone for that. An occult vascular injury, 61% have gone for that one as being the hardest to diagnose. A nervous injury, 4%. A fracture, 2%. And a soft tissue injury is 4%.
Excellent. That's a brilliant result. Giles, are you good sharing my screen?
Yeah, we can still see your screen. Perfect.
Fantastic. Excellent. So top marks to everyone. The two most difficult questions to answer is, has this knee been dislocated? Because it's extremely difficult to make that diagnosis, especially without any obvious witness history and confirmation. And has there been an occult injury? So yes, an occult injury is really difficult to diagnose, and for that reason we suspect it until we've imaged the vasculature and excluded it. So moving on to downgrading philosophy for ligament injuries.
Could we just ask one quick question? We may actually go on to this in a bit, but
sure.
It's from Nathanakorn, and how could you differentiate the multiple ligament injuries of knee in the case of a minor or moderate with an unclear MOI? Which special investigation do you recommend for assessment?
Sure. So if an MRI scan suggests there's been a multi-ligament knee injury, then I would correlate that with examination findings, assuming the patient is comfortable enough to tolerate examination. Often MRIs and MRI reports will overcall the ligament injury. So there can be a grade 1 injury clinically, which is to say that it hurts if you stress the ligaments, but there's no instability, and it can be called as a significant tear, as a grade 2 tear on MRI. So the real key is clinical examination. I completely accept that can be difficult, especially in pediatric and adolescent patients, and in the presence of significant pain and apprehension. But clinical examination is really the key. The gold standard is an examination under an anesthetic, but that really is only an option if you've already committed to a surgical course of treatment and the patient is having an EUA at the beginning of their procedure.
Brilliant. Yeah, that's perfect.
Excellent. So moving on, guys, to knee ligament healing and downgrading philosophy. So we know that due to anatomical and physiological attributes, the PCL and the MCL have a superb ability to heal and downgrade their injuries as long as they're treated appropriately and they're held in an appropriate anatomic and physiological position during especially the early phases of healing. And that by comparison, the ACL, LCL, and post-lateral corner have less ability to heal, not no ability, but significantly less ability to heal and downgrade. So in terms of conventional treatment strategy for multi-ligament injuries, our treatment has always been to exclude and to treat any life or limb-threatening injuries, exclude any neurovascular injury, as we've already discussed, hold the joint in a reduced position, often by use of an external fixator, and then plan surgery at some point thereafter. Often what limits onward surgery is either concomitant systemic injuries, head, trunk injury, spinal injury or similar, or other things that can limit access to surgery can be logistics and resources. Within the space of multi-ligament care, there have been many debates, and these debates have raged throughout the 90s and noughties, and the main questions have always been, when should we operate on these patients, whether we should be operating hyperacutely within the first few days, early within the first couple of weeks, or late beyond 4 to 6 weeks, and how do we do these operations? What graft do we use? Do we perform the procedure entirely arthroscopically? Do we do open surgery? And these are the main topics that we've discussed. But we've very rarely discussed whether we should be treating these injuries surgically, and often, forgive me, whether we should be treating these patients surgically or conservatively, with conservative treatment often being used as a get-out-of-jail-free card for the type 2 low energy heavy set patients who we don't get great results with surgically. So in terms of bracing and downgrading, I've gone on a bracing journey in my career so far. So I've been a consultant now for coming up to 12 years. And during this time, I've treated PCLs and isolated PCL injuries with bracing and downgrading. Initially, I used a static 3-panel cricket pad type splint with a calf cushion. And this was used for both conservative treatments of isolated PCLs or for post-operative splinting to offload and protect a soft tissue graft after soft tissue PCL reconstruction. The problem with this brace is that it's quite poorly tolerated. It's almost impossible to get a pair of trousers on over it. It tends to slip down the calf and continually has to be readjusted. So it's very hard to get it to anchor above the patella so that you can suspend it appropriately. It predisposes to stiffness. To manage that stiffness risk, one would have to arrange manual physiotherapy for protected passive mobilization of the knee while continually maintaining an anterior tibial translatory force through flexion to protect the PCL while mobilizing. I then moved on to using the PCL jack brace once this became available onto the market. And this again I used for conservative treatment and for post-op bracing of soft tissue grafts. The advantage of this is that it is a dynamic brace allowing knee movement and helps to minimize the risk of joint stiffness and arthrofibrosis. And this device maintains a tibial anterior translation throughout knee flexion. However, it's the same resistance at whatever degree of flexion you apply. So you have the same degree of anterior tibial translation whether you are at full extension, at 30 degrees, 90 degrees, or more. This device was available off the shelf, but again, patients complained that it was a little bit bulky and a little bit uncomfortable and wasn't very well tolerated. More recently and currently, the staple for my practice is the use of the PCL Rebound brace. I use this because it's a lot more ergonomic and low profile. It's very well tolerated and very comfortable. It's available prefabricated and it has a very sound design rationale. So again, it's a tensioned sprung brace providing anterior tibial translation through knee flexion. But the difference between this and any other PCL brace available on the market is that the anterior translation force increases with flexion angle. So as you flex, you bring your hamstrings into play because they have an appropriate moment arm to start acting on the tibia. And as they start to come into play, the anterior tibial resistance increases. So that design rationale is quite appealing and certainly makes sense. So my indications gradually grew as I got more confident and more comfortable with the use of the PCL Rebound, and as I saw really good results, I went from using it only for isolated PCL injuries to using it for combined PCL, MCL injuries, and then I've started using it for PCL, MCL, ACL injuries with a view to downgrading the PCL and the MCL, and if downgrading is achieved and good prehab is achieved, then having a dialogue with the patient about later having an isolated ACL reconstruction. So converting a complex multi-lig patient into a simple ACL, which we've done many, many times in our practice. The frustrations are that these braces need to be applied in the acute window at presentation, ideally in the first 14 days, with still benefit being attained if you can brace them within the first 21 days. But anything beyond 21 days, there really is very little efficacy in bracing. The problem is that patients often present late to a specialist soft tissue knee clinic, even in the context of an acute hot knee clinic, which we run both at St. Thomas's and at Fortius. These patients can still arrive late. And there is a tendency when these patients present, having gone through the A&E system, for them to present either excessively stiff with arthrofibrosis or with laxity and a very loose knee. So either too hot or too cold, not just right. And this is something that I'd like us to really explore because I think it's quite important. So let's chat a little bit about the multi-ligs. So multi-lig patients represent approximately 14% of all polytrauma presenting to trauma centres throughout the UK. They don't present to the soft tissue knee service, they present primarily to the trauma surgeons and our trauma colleagues. And in the acute phase, there's a tendency for them to be either undertreated or overtreated, with undertreatment resulting in them presenting quite lax and loose to the knee surgeon, and overtreated with them presenting quite stiff. And often the knee unit involvement in these patients' care can be quite delayed and down the line. So patients who are undertreated, as I mentioned, present late, and they have inadequate immobilization, often being placed in a 3-panel splint or a poor black slab, and they have persistent instability. And these patients have essentially missed the boat and missed the opportunity to have their PCL and MCLs downgraded. There's then the category of patient who's overtreated. So again, these patients present late, and these are the patients who are often put into an external fixator. The problems with external fixators is that often reduction may be inadequate or may be lost having had the joint adequately reduced in theatre. There's a significant risk of arthrofibrosis, as well as contamination and disruption of the soft tissue envelope with pin site infections. And once an X-fix is applied, it's not possible to get MRI imaging of this patient's knee because the X-fixes are not MRI compatible. There was an MRI compatible external fixator system on the market. Unfortunately, it has recently been withdrawn. So why is X-fix still used? Well, it's still taught as part of core management of polytrauma patients, both as part of ATLS teaching as well as wider training of our registrars. The clinician responsible for these patients' care is a trauma surgeon, not necessarily a soft tissue knee surgeon. And the knee is not the priority for many of these patients who present. Priority is usually saving their lives and saving their limb. And the knee itself is not often seen as a key priority, which is understandable. So what we have is we have knees that are undertreated and we have knees that are overtreated. And what we want is we want the Goldilocks knee. We want the just right knee. And that's a knee that's mobile, supple, where the chondral surfaces have been nourished and lubricated with synovial fluid, but where the ligaments have been kept in the appropriate physiological and anatomical position and to the correct length to allow early phase healing. So the problems with the pathway that these patients follow at present is that initially they have their injury, they come to A&E and they are assessed, they're taken to resus and resuscitated, they receive their acute care, they are transferred to the ward where they have their early recovery, they are then discharged and are seen by the knee service at some point after discharge. And often these patients can be lost to follow-up for some time. So the knee service sees them at follow-up and sometimes will be involved in their care during their early recovery phase on the ward. But what we really need to do is we need to be involved much earlier on in this pathway so as to improve patient outcomes and have the best impact on long-term function. So as I've mentioned, we have late involvement of the knee service. The knee is not the priority. Once these patients are ex-fixed, there's issues around MRI compatibility, and there's a propensity to either be overtreated or undertreated. And when these patients are lost to follow-up or have delayed follow-up, I often refer to them as the lost knee tribe. And you know, I think there is the potential and the risk of them coming to harm during this lost period. So the trauma rebound concept was born of all of the things that we've discussed and all of these frustrations. So Össur and I got together and talked about how we can impact and leverage some of the orthotics that we use in our routine practice to help these patients and improve their care. So what we've developed is a new hyperacute pathway with a new early protocol, primarily targeting our trauma surgical colleagues to encourage them not to ex-fix these patients, but instead to splint and then brace these patients appropriately. So we looked at what we had available and developed some modified products. So the pathway involves the use of a 3-panel knee splint with calf cushion, which critically is MRI compatible. So the patients can have their MRI scan while they are splinted. Once we know the injury pattern, we then are able to think about using the PCL Rebound brace, a new version of that, which comes in red, which is the trauma rebound brace, and this is set in terms of range, in terms of tibial translation pressure, and in terms of how much we allow the patient to weight bear. Those 3 parameters are based on the patient injury pattern and are completely protocolized, and that's available with the pathway. And we combine that with a dynamic foot up splint. So for those patients who have a neurological injury and a foot drop, the foot up splint helps to keep their foot plantigrade, minimizing the risk of the evolution of a fixed equinus. And in those patients who don't have a neurological injury, the foot up splint provides dynamic resistance for calf activation to minimize risk of any DVT. So the new pathway involves appropriate clinical assessment of the patient in A&E resus. And once the patient has been examined by the attending orthopedic surgeon, the patient is placed in a 3-panel MRI compatible splint with calf cushion. And the examination findings are actually documented on the splint itself, which is something taken from military practice. The patient has an MRI scan within a day or 2, other injuries allowing. And then based on their injury pattern demonstrated on MRI, the patient is then fitted with their foot up splint and trauma rebound knee brace to allow for PCL and MCL splinting, bracing and downgrading. The patient is then rehabilitated, mobilized, discharged, and hopefully arrives to the knee surgeon at 2 to 4 weeks thereafter with a quiet knee, which is mobile and has been given the best opportunity for downgrade. So just to recap that briefly, initially the patient presents in casualty to the emergency room. They are examined and attended to by the orthopedic surgeon. They're placed in a trauma splint, and findings are documented. An MRI is performed, and then the patient is referred to the acute physio team or orthotist team. This varies between units for fitting of their rebound brace and their foot-up splint. Once the brace has been fitted, the patient is then mobilized. They're given range of movement exercises. They're advised regarding quad and glute activation, as well as being given patella mobilization. There's access for the use of a cryo cuff or similar cooling device or simple icing. Patient is then discharged with appropriate follow-up and is then seen later on in clinic in a more common settled environment by their knee surgeon for definitive assessments and definitive treatment plan. So in my practice, wherever I can, I use bracing as definitive treatment, and then I operate on whatever may or may not be unstable following having exhausted conservative treatment and exhausted a downgrading strategy. Now, if your local surgeon feels that they can get a better result in that patient with an acute operation, then that's absolutely fine. The patient can be listed for surgery at 2 weeks and go on to have their surgery. The patient hasn't been overtreated or undertreated, and they've got a mobile, quiet knee with a good range. This pathway can be used as a definitive treatment, or it can be used as a temporizing bridge until urgent surgery is performed. So, as I've mentioned, what we want to achieve is safe clinical assessments with immediate splintage using MRI-compatible products with functional bracing and allowing patient rehabilitation and allowing the soft tissues to heal and settle. There is a significant side benefit, which is that the use of this pathway dramatically reduces the cost to service providers and to the health service of external fixation or similar. And as I've mentioned, the pathway is not necessarily intended as a definitive treatment protocol for all injuries, but I definitely feel that a majority of injuries are amenable to definitive care by way of ligament downgrading. There are some important exclusion criteria, as you may expect. These include concomitant significant vascular injuries, where an MDT approach is required with your local vascular colleagues, and they may require definitive skeletal stabilization in order to perform a vascular reconstruction. And for this, XFIX is certainly the way to go. Where there are significant soft tissue concerns, in terms of damage to the soft tissue envelope, where the patient's body habitus precludes the use of bracing, or where pressure care may be an issue if the patient is moribund or is likely to be in ITU for very long periods. I know it goes without saying, but these patients must all be VTE risk assessed and must receive VTE chemical prophylaxis in accordance with local guidelines at your unit. So,
there are a few questions. First of all, sorry to interrupt.
No problem.
First one is from Dr. Mike Burden, who's an SEM consultant. For PCL, MCL, and ACL case, where you've downgraded the PCL and MCL with a brace, how long would you typically wait before deciding on an ACL recon? Would you give them 3 months out of the brace and see how the ACL's doing, or have a narrow window for surgery, for example?
Excellent. Well, thank you very much, Mike, for that question. And I hope you and the family are keeping well, Mike. You still owe me that coffee you promised me. With regards to your question, the downgrading segment of care takes an absolute minimum of 3 months in a brace. And I like to add on at least another 2 to 4 weeks, weaning out of the brace quite gradually thereafter. then the patient needs to complete their course of ACL prehab physiotherapy, attaining their ACL prehab prerequisites of terminal range, good, comfortable, confident, symmetrical gait, and good limb control. At which point I have a discussion with the patient exactly as I would had they had an isolated ACL injury from a ski trip or football injury. And we talk about the pros and cons of either conservative treatment with the aim of becoming a high-functioning coper, or alternatively the option of surgery by way of an ACL reconstruction, depending upon their aspirations, lifestyle, and sporting profile. Of course, all of that is contingent on the downgrading having been successful, but that's generally the time course. So yes, it takes a long time, but I think we definitely achieve better quality and results and better functional results. You know, myself and many of my colleagues have commented that often a downgraded, conservatively treated MCL or PCL feels more stable and more physiological than a reconstructed MCL or PCL. So it's definitely our preference.
Okay, that's brilliant. And what range of motion would you set in, for example, the first 6 weeks? That's a question from Andrew Hall.
So, the range of movements initially is restricted because we want to limit how much hamstrings action takes effect. So, in my practice, I would usually give them 0 to 30 for the first 2 to 4 weeks, and then gradually increase it thereafter. For Andrew, Giles, is there any chance we could maybe email Andrew the protocol that we've written?
Yes, absolutely.
Ranges.
We can actually include that in the follow-up questionnaire as well. So
that would be fantastic. So I'd just like to share a couple of case examples, guys. This is a very simple example. So this is a 26-year-old footballer who presents with a grade 3 clinical and radiological MCL injury with a high-grade ACL sprain with ACL incontinuity. You can see here on the image on the left, there is significant disruption and physiological laxity and redundancy in the MCL. You can also see, if you look carefully, guys, and compare left to right, the medial joint compartments on the left is open by about 2 millimeters, maybe 2.5 millimeters. And if we compare that to the right, that joint space is now closed. The MCL is definitely thicker. There's low signal, and there's no redundancy or laxity. And this interval is a 1-year interval between presentation and a repeat MRI scan taken at 1-year interval. Next is case number 2. So case number 2 is a 16-year-old academy football player who presented to me with a complete ACL rupture, a grade 3 MCL, a partial proximal lateral collateral injury, and a partial PCL. And if all of that wasn't enough, they also had a partial patellar tendon injury. So at presentation, you can see once again a significant grade 3 MCL injury, and this interval is 6 months. So at 6-month interval, significant MCL healing, remodeling, and I think most of us would agree you'd be hard pushed to tell that the MCL on the right had ever been injured. Here we can see the proximal LCL injury, again healed and downgraded. The partial injury to the patellar tendon, healed and downgraded. And lastly, a partial injury to the PCL, once again healed and downgraded. This young lady made a superb recovery, and she was spectacularly committed to her physiotherapy and rehabilitation. And she's a case example of Mike Burden's question. So we had a really long chat about her aspirations for the future. She was delighted with her knee, but lacked trust and confidence, and definitely wanted to return to football with the aspiration of playing professionally. And she went on at 9 months post-injury to have an autograft ACL reconstruction and a lateral tenodesis. The lateral tenodesis was added in because she was a little bit hyperlax and she was quite high demand in terms of her sporting profile, and she has since returned to football. So a poll, Giles.
Okay. So we have the final poll. I'm just going to pop that up now. So would you consider using ligament bracing as an acute, using bracing in an acute multi-ligament knee injury now? So yes or no. This is already pretty polarizing before, so. Okay. So we've got over 80%. And we have, if I just share those, so 99% would consider using this type of approach for their multi-ligament knee injuries.
Excellent. Thank you very much, everyone. So, forgive me, I'm just, there we are. So to conclude, it's really important to think dislocation when you see an acute, angry, swollen knee. It's extremely important to think about occult vascular injury. And if you would consider bracing as part of your practice, that bracing needs to be started really quite early on, within the first 14 days, and ideally within the first 7 days if possible. So one of the advantages of working in the tallest hospital in the Northern Hemisphere is that we get some fantastic views. And if you ever are in London and have time, please do reach out. And it would be great to grab a cup of coffee, chat about all things knee, and I promise you the best seat in the house. Thank you very much, everyone, for your time. And please do feel free to ask questions. We've got loads of time, so please do share some questions.
Okay, brilliant. Thank you very much, Mr. Ajuied. There's certainly quite a few questions, so we'll start sort of working through those if that's okay. Okay. Question from Rupert Clifton. Do you believe in early LCL repair or reconstruction?
So if there is a complete LCL injury, I do believe in reconstruction, most definitely. But if the patient has an LCL, PCL injury, which is a very common injury pattern, so LCL, postlateral corner, PCL, I would brace them to downgrade their PCL. Interestingly, the postlateral corner does have the potential to tighten up as well. And if they remain laterally deficient, I will then go in and do a modified Larson reconstruction in the delayed setting. There's the one thing that we need to be really clear on, in that scenario, very common scenario, PCL, postlateral corner, LCL, there is no place to do anything laterally and leave the PCL untreated. Okay, so the linchpin of knee stability is the PCL. You cannot reconstruct anything around an unstable PCL. So I would not reconstruct the LCL and brace the PCL and hope that downgrades.
Okay, fantastic. And a question from Carolyn Aldridge: what's the best way to rule out an occult vascular injury?
So usually the best way is definitively by investigation. The reason I'm being a little bit stuttery about answering that question is that it kind of varies from unit to unit, and it kind of depends on what your vascular surgeons prefer. So the default for most orthopods is a CT angiogram, which are the images I showed earlier. A few vascular units are happy to use MRI angiography, so MR angiography, and some may even suggest that ankle breaker index is enough on its own. But most orthopods, I think, would agree that they would like a CT angiogram. So in my practice, I use a CT angiogram. Okay,
and perhaps one last question. It's kind of in search of the Goldilocks knee, as you put it. But in your opinion, is it better to have a knee that's too stiff or too lax? Which is your preference of those two?
That's a brilliant question, and the answer is definitely a knee that is too stiff. And I'd like to kind of explain the reason. So a knee that's too stiff has arthrofibrosis. So limited patellar mobility, lack of terminal extension, lack of terminal flexion. But at least that knee's had the chance to possibly heal and downgrade the MCL and PCL. And I'm pretty good at managing a stiff knee. So yes, it's difficult and it requires a diligent multidisciplinary approach, but with good anesthesia and arthroscopic arthrolysis, with good inpatient physio and follow-up physio, we've got strategies to get the range back, and that would be a stable mobile knee. When I've got a very loose knee, then all bets are off. Surgery has to stabilize that knee. There's no other mechanism. So I think I want my Goldilocks knee, but given the choice between too cold and too hot, I want too cold.
Okay, brilliant. And the second I said just one more, lots more questions came through. So there's one or two if you don't mind, Mr. Adil.
No problem.
So there have been a few questions about the foot up, for example. So it's from a few different people. So when and why would you use that, and why would you necessarily use that over a more rigid style of orthosis?
Forgive me, Giles, with reference to which orthotic is that question, sir?
The foot up. So you mentioned about using the foot up to prevent the drop foot.
Yeah.
Could you sort of discuss around that?
So the reason we chose that is that we wanted something that was soft to minimize risk of, so we don't want any hard thermoplastic type firm orthotic because of the risk of the foot being insensate and the risk of potential pressure issues for the skin. The advantage of having something dynamic means that in those patients who don't have a neurological injury, they can push against it to activate their calf and activate their calf pump, improving their venous return and venous flow and reducing the risk of stasis and DVT. Whereas a static orthotic wouldn't allow you to do that.
Okay, fantastic. So if you have any other questions, we will kind of come back to those, and we'll send through a complete list to Mr. Ajuied and try and get answers to those as many as we can. Just really remains for me to thank Mr. Ajuied. Fascinating talk. It's an area that the hot acute knee is something that not all of us tend to see as an audience. So it's fascinating to have that insight. So thank you very much, Mr. Ajuied. Really appreciate your time. Really interesting. It just really remains for me to say that the next session will be a week on Wednesday. So there's a little bit of a gap before the next one. And it will be with Mr. Paul Tricker, discussing the ruptured ACL, child to adult, and also OA knee, an evidence-based treatment pathway. So we're starting to look much more about how we can return back to work once the lockdown ends. So Mr. Ajuied's talk and also Mr. Tricker's talk, we'll start to talk a little bit more about how we can manage this patient population once we return. So thank you again to Mr. Ajuied, and we will see you soon next week.